Good morning. The topic for today's discussion will be on removable appliances. So, as the topic discusses, removable means something which can be removed, an appliance worn by the patient. In pediatric dentistry, sometimes we have to treat conditions, simple treatment conditions, which can be done with the help of those removable appliances. So, removable appliances are those appliances which are not fixed to the teeth and can be worn by the patient as and when required. It can be used to treat various clinical conditions. Simple. The fabrication is very simple that it does not require much time, and it is cost effective for the patient because the components are very cheap. So before going into detail about each appliance, we should be knowing the different components. That means parts. The different parts of the appliance can be classified into active components and retentive components. Active components means which cause the bones of tooth movement. Under that we have bows, springs, retractors, elastics, screws. Retentive means you don't want the appliance to move or shake when the patient is eating or talking. So under that we have Adams class, C class and triangle class. Let us go one by one. Active components bows. As you can see in this picture, it is a thin segment of wire running across the teeth. Mostly it is given from canine to canine. So as you can see here, it is touching the teeth. So it can be used to push the teeth behind or prevent the teeth coming more forward. So active means which is causing some tooth movement. So there are different varieties in this bows like short labial bow. As you can see in this picture, it is cut, so it is called a split labial bow. Here the loop is in the reverse direction, so it is called as reverse labial bow. But the basic main action of bows is to cause some tooth movement. So it is an active component. Then you have something called as springs or retractors. A thin wire is given multiple turns in the form of coil. So it is called a spring. So what is the basic action of spring? It is once you turn the wire in the form of a coil, it becomes like a spring. So it wants to come back to its original position. So it exerts force. So when it is exerting force, it is causing some tooth movement. The same is in the case of retractor. Retractor means pushing. So the active components of the springs of a removable appliance are springs and retractors. Here you don't have to know the names. So we are just having some examples like finger spring. Here it is in the shape of a Z, so it's called Z spring. Here it is bent in the shape of a U, so it's called a coffin spring. Retractor, so you see the design of the retractor, it is touching up specific tooth. So it is used to push that particular tooth in the proper arch. Most of the time in children, premolars, they do not erupt in the proper position. So these retractors can be used to push the specific tooth in alignment with the arch. Then the next active component is screw. Screw we see in our daily lives. The same can be incorporated in appliances, except that the size of the screws are many. As you can see, the acrylic plate is split, and on either side we have the screws attached. You have a key, so the patient is made to come every 1 week or 2 weeks, and the patient is made the screw is tightened or loosened accordingly how the condition of the patient, depending on the condition of the patient. So screw causes some tooth movement. For example, in this particular situation, if I'm going to tighten the screw, it pushes the tooth forward and the molars are in the stationary position. So screws are mainly used for moving a segment of teeth. Depending on the patient, we can modify it whether you want the full anterior segment or the posterior segment to move. So it is an active component. This you would have come across elastics, which we use in our daily lives. The same can be incorporated in removable appliances or fixed appliances to cause exert force. Since elastic is exerting a force, it causes tooth movement. So I recap. The four basic active components are what? Labial bow, springs, retractors, screws, and elastics. Then you have the retentive components. As the name indicates, for retention. You don't want the appliance to move, to fall out. You want it to be retentive. So some clasps are given in the form of C class, Jackson's clasp, Adams clasp. The most commonly used retentive component is your Adams clasp. In children with erupting teeth, you cannot give this Adams clasp. So in such situations, we go for the C clasp. What are the advantages of this removable appliances? The basic thing, it is removable. So it can be removed for toothbrushing. The oral hygiene of the patient is not compromised. Since it is having a full base plate, the palatal coverage is more, so it increases the anchorage. Anchorage means securing, it means retention. The retention that is very good in the case of removable appliance. It takes a short chair side time. Patient comes to your clinic, you take an impression, that's it, and you send the patient. All the processing is being done in the lab. So patient does not have to sit in your office till the appliance is being done. So it is a very big advantage. The components are very cheap because it uses very basic components like wire components and acrylic. So very cost effective for the patient and less risk of iatrogenic damage. Hydrogen damage means damage caused by the treatment. Most of the times, because of fixed braces, it causes root resorption. That is all not happening. It is very less. The incidence is very less in the case of removable appliance. But there are some disadvantages when you use removable appliance. It applies a single point of force. That means what? The force is acting only on a specific direction. So this appliance can be used for only simple clinical condition causing tipping movements or rotation. You can use only in simple malocclusion. You cannot use in very complicated procedures. It is heavily dependent on the patient compliance. So if the patient does not wear this appliance, your treatment becomes a failure. So you have to give it for patients who are very highly motivated, who will listen to your instructions and wear it daily. It is uncomfortable to the patient at the beginning because it is very bulky, so patient may not be able to eat or speak properly. It is usually inefficient for multiple individual tooth movement. As I said earlier, it cannot be given in complicated malocclusion cases, so it is very inefficient in such typical cases. The patient has to have certain amount of dexterity and skill. So you have to teach the patient how to remove the appliance and how to place it back. So it can be given for children who are older enough, who have the proper handling technique of the appliance. You cannot be giving it for very young patients. Sometimes they have to wear the appliance and go to school, so they have to have the proper dexterity to handle the appliance. In epileptic patients who have uncontrolled seizures, you do not give this removable appliance, especially it's very commonly seen in children, so it is not indicated. In some children, you have acrylic allergy, so you do not give this appliance to such children. In which conditions are the removable appliances indicated? The first and foremost for minor orthodontic correction. As the teeth are erupting in the child's mouth, you might notice that the teeth are not erupting in the proper arch, they are not in the proper position. You might want to correct it at the earlier situation. So in such conditions like arch expansion, crossbite correction, deep bite correction, closure of midline diastema, for simple clinical problems, you can make use of this removable appliance. Next is correction of oral habits. Very, very commonly seen in pediatric population like thumb sucking, mouth breathing, tongue twisting, bruxism. You can give this removable appliance for correction of oral habits. And the last one as a retainer after completion of fixed orthodontic treatment. You would have seen in your cousins, most of them will be wearing a retainer after the fixed braces treatment is completed. Why? You don't want the teeth to go back towards older position. You want them to be in the same position. So in such cases, removable appliances can be placed. Next comes your indication in pediatric dentistry. In growth modulation and malocclusion correction, children, sometimes when they are growing, the problem is not in the dentition, the problem is there in the jaw. It is called a skeletal malocclusion. The maxilla might not be growing properly, the mandible might be growing too much. You want to modify the growth of the jaw. So that is called as growth modulation. In such cases, we give some removable appliances called as functional appliances. The next most important is your space maintenance. Most of the times children come to us in a very late condition where we cannot save the primary tooth. We have to go for multiple extractions. So that extraction space has to be maintained. So we give in the form of removable appliance, which is called as removable space maintainer. In children having cleft lip and cleft palate, eating is not proper because there is a cleft in the palate. They are not able to talk properly. So you have to give a removable appliance in the form of feeding plate or obturator. In children having some syndromes like ectodermal dysplasia, rampant caries, sometimes you have to extract all the teeth. So what happens? You have to give a complete denture. In such cases, it's in the form of removable appliance. So the commonly used appliances in pediatric dentistry are the follows. We can go one by one. First one being the Hollis appliance. This Hollis appliance was designed by Charles Hawley in 1920, so it has been almost 100 years since this appliance has been designed, and till date we use the basic same design. It is the most frequently used retainer after fixed braces treatment. So as you can see, it is basically containing a labial bow on either side the Adams clasp. So it has a very simple design. So as I said, you have a short labial bow running from canine to canine, and then you have Adams clasp on either side. So this is the basic appliance design. This labial bow, instead of being short, sometimes you can make it long, running from one premolar to the other premolar. You might want to push the canines also behind. So at that time you incorporate something called as long labial bow. The second modification is that to the Hollis appliance, you attach an anterior bite plane. Can you see in this picture? You have an acrylic bulk added. So this is given in the case of anterior deep bite. In children, anterior deep bite is very common. You can correct it very effectively by incorporating this anterior bite plane to the Hollis appliance. Then the third one is midline diastema. So how is the label bow in this situation? It is split, it is cut. So what happens is that gradually both incisors come towards each other and the midline diastema is getting corrected. So these are the modifications done in the Hollis appliance. How to motivate the child to wear this appliance? You can make it more attractive by adding their favorite color, their favorite stickers, and their favorite icons to make it more customizable for them, and so that they are highly motivated for wearing a long period of time. So the advantages of this Hollis appliance is that it is very easy to fabricate, it is having a very simple design, it is causing minimal patient discomfort because of the simple design and the reduced bulk of the material. Most of the child patients accept this appliance very easily and it is very cost effective. So it is having many advantages. Next, moving on to the Catalan's appliance or the lower anterior inclined plane. As you can see from the design of this appliance, can you see it is mostly given in the lower arch. It is an acrylic bulk added to the lower incisors. What do you see in this picture? Here your child has got anterior crossbite. Anterior crossbite means what? The upper incisors are inside and the lower incisors are outside. It is in the reverse direction. So it is called as crossbite. It is a very commonly seen clinical condition when the incisors are not erupting in the proper position. You can correct it very easily by giving this Catalan's appliance. As you can see in this picture, this is the Catalan's appliance placed. So what happens over gradually over 1 to 2 weeks, the anterior crossbite gets corrected. This anterior crossbite can be used for a single tooth or a segment of teeth. Sometimes 2 or 3 incisors might be in the crossbite. So they can be treated simultaneously by giving this lower anterior inclined plane. The most important feature is 45-degree angulation. Because of this 45-degree angulation, as you can see in this picture, the tooth which is in crossbite, it comes in contact with the appliance and it starts moving forward. It causes a tipping movement and causes the upper incisor to move forward and the crossbite position gets corrected. Next, moving on to something called as removable space maintainer. As I said, sometimes it is necessary to extract a badly decayed primary tooth. The space is created. We want to maintain that space. If this space is not maintained, what happens? It results in abnormal axial inclination of teeth. That means the adjacent teeth are not straight. They start drifting. Spacing between teeth gets caused, and there is a midline shift. We want to avoid these problems. So we give something called a space maintainer, which is a device used to maintain the space created by the loss of a deciduous tooth. And removable space maintenance are one type in which it can be worn and removed as by the patient as and when required. This removable space maintenance can be classified into two types, functional and non-functional. Functional means, as you can see in this picture, we add artificial teeth. So how does this design look? It resembles the same which you give as a removable removable partial denture which you give in prostho. So when you have artificial teeth in them, it is called as functional space maintainer. Non-functional space maintainer means it has only an acrylic extension. You don't have this artificial teeth. In the place of the artificial teeth, you have the acrylic extension. So I think this will explain it well. So functional means it is having a artificial teeth. In this situation, the upper incisors are lost and there is one primary molar lost. So we are adding artificial teeth in the space maintainer. Here it is only an acrylic extension. So it is called as non-functional space maintainer. Now, what are the indications of this removable space maintainer? Sometimes children come with badly decayed upper incisors. We have to extract. We cannot do pulp therapy. So what happens? The child stops smiling. Child stops opening the mouth. The child feels very shy and ashamed. So to improve the aesthetics, you can go ahead with giving this removable space maintainer. Some children, the oral hygiene is very poor. You cannot give a fixed space maintainer. You have to go for this removable space maintainer. In children who are having cleft lip and cleft palate, you have to close the cleft. So you have to give the removable space maintainer which acts like an obturator. Sometimes permanent teeth are not fully erupted. You have a permanent molar which is erupting. So you cannot place a band. You cannot do fabrication of a fixed space maintainer. In such situations, you have to go for a removable space maintainer. Sometimes children come with multiple loss of deciduous tooth. So many teeth are missing. You cannot go for fixed space maintainer at all. You have to go for removable space maintainer. So these are the indications in which you go for removable space maintainer. What are the advantages? Because it can be removed, it is very easy to clean. So the oral hygiene of the child is maintained. It restores the vertical dimension because you're going to add an acrylic or the artificial teeth. The vertical dimension of the patient is maintained. It can be worn part-time. Suppose you wear it continuously, what happens? Tissue irritation all happens. But this removable space maintainer can be removed, so it can be worn part-time. It even serves other function like mastication because we have artificial teeth. The child can eat properly, can chew the food properly. The phonetics is good, the speech is improved, everything is having other function. Dental checkup of the mouth is possible because you can ask the patient to remove the appliance and you can see if any new caries is there. Spaces can be made in the permanent teeth. You can create some space within the appliance for the permanent teeth to erupt too. And they also stimulate the eruption of the permanent because they come in contact with the underlying gums. It stimulates the eruption of the underlying permanent teeth. So you have lots of advantages of this removable space maintainer. What happens if it does not, the child does not follow your instructions? Sometimes, since it is removable, children they do not know to handle this appliance. They might lose it or they might break it. So you have to fabricate it again. Uncooperative patients might not listen to your instructions. They might not wear it. Since it is having some wire components attached to the teeth, the lateral jaw growth might be restricted. They may cause irritation of the underlying soft tissues. So there are many disadvantages of this removable space maintainer. Now moving to something called as complete denture. In children who are having rampant dental caries, there is loss of multiple primary teeth. You have to extract. So you have to go for a complete denture, or in syndromes like ectodermal dysplasia causing anodontia, you have to give a complete denture. This complete denture is given for restoring the function and aesthetics of the patient. These dentures can also act as a guide for the underlying permanent molars for eruption. What do you see in this picture? So this is a denture given, complete denture given to the child. But as and when the permanent molars are erupting, we trim the posterior border of the denture so that they can erupt. Similar way, the permanent, you create a window, the incisor area as the permanent incisors erupt. So you can modify the complete dentures in children as the permanent teeth are erupting. So we have to give the design of the complete denture in children such that we have to accommodate the erupting permanent teeth. So they have to be adjusted, they have to be contoured as and when the permanent teeth erupt. Next, the important one is your oral screen. Oral screen is given in cases where the child is having mouth breathing habit. So this is the design of the appliance. As you can see, it is completely closing the mouth. So the child cannot do this mouth breathing habit. This oral screen is otherwise called as vestibular screen. It was introduced by Neville in the year 1912. So it acts on the principle of force application and force elimination. In children who are having this mouth breathing habit, what happens is that the mouth is kept in open for a long period of time. So what happens? The lip becomes very hypotonic or very relaxed. It is not in a proper muscle tone, whereas the cheek muscles are hypertonic. They are very stretched. They exert excessive force. So as the oral strain is applied, what happens? The it causes force application. That means you want the lip muscles to exert more force. So it is like a force application. Force elimination means you don't want the cheek muscles to act excessively on the side jaws. So that is force elimination. So it is causing a balance of the forces over the teeth. Indications of oral strain. The first and foremost indication is to stop this mouth breathing habit. Sometimes it can be used for stopping thumb sucking habit, tongue twisting habit, lip biting habit, and cheek biting habit also. It is used to perform muscle exercises. Sometimes muscles of the children are very relaxed. They are not very normal tone. You want to make it more strong. You want to strengthen the muscles. So that time you can give this oral strain to strengthen the muscles. It can be used to correct the mild anterior proclinations. So as you can see the design, it touches the proclined upper incisors and pushes it backward. So it is used to correct your mild anterior proclination. There is a modification done to the oral screen called as HOTS modification. As you can see in this picture, to the oral screen a metal ring is being attached. Why is this metal ring being given? This metal ring is given so that the child can hold the metal ring and can compress the lip muscles. They can do some lip muscle exercises. Most of the times, children who are having this mouth breathing habit or class 2 malocclusion, the lip muscles will be hypotonic. Hypotonic means they do not have sufficient strength. So you want to give some exercises to strengthen the lip muscles. So this oral stream can be given with HOTS modification with a metal ring so that they can engage in this lip exercises. So that is the HOTS modification. Now what do you see in this picture? The same oral screen is having different types of holes. Imagine giving a oral strain to a child who has been doing continuously mouth breathing habit. Can they correct this habit within one day? It's not at all possible. They cannot breathe through their nose in one day. You have to gradually stop the habit. So that is what is shown in the picture. Initially, when I gave the oral strain to the patient, it has got lot of holes so that the child can still breathe through the mouth. As the child continuously wears the appliance in 1 week, 2 weeks, I gradually close the number of holes. So at the end, I completely block. Now the child is trained to breathe through the nose. So that is the most important thing to be given when giving an oral strain. The child has to wear the appliance at night and at least 2 to 3 hours during the daytime. The child has to maintain a lip seal, and sometimes the child may complain of tissue irritation as and when you have to do the trimming of the appliance. Next is the removable palatal crib. So what do you see in this picture? It is a basic Hollis appliance where you have something called as palatal crib. Crib means fence. This is an appliance given for stopping tongue twisting or thumb sucking habit. Very commonly seen habit is your thumb sucking or your tongue twisting habit. Tongue twisting means the child puts the tongue forward while talking, while eating. So it results in anterior open bite. So you can give this habit retraining appliance. It acts like a reminder. So when the child is putting the thumb or digit inside, it touches the crib. So child gets reminded to stop this habit. The same way in the tongue twisting habit. When the child is talking, the tongue comes in contact with the palatal crib. So child is reminded to push the tongue backward, not place the tongue forward. So it acts like a reminder to the children to stop the thumb sucking or your tongue twisting habit. But there is a disadvantage of giving this appliance. Because of the complicated design having lot of extension, what happens gradually? Food gets entrapped. If the child does not clean this appliance properly, what happens? It causes a oral malodor. So proper maintenance of this appliance is required. And since it is having some crib-like thing, the child will have some difficulty in speaking in the initial 3 days. Gradually, within 1 week, you will find out that the child has adapted. So this is just a temporary discomfort. Gradually, over 1 week, the child will overcome this discomfort and then adapt to usage of this removable parental crib. Then you have something called as obturator. As you can see in this picture, it is a child who is having a cleft palate. There is a cleft in the palate, so patient is not able to eat properly. The child is not feeding properly. This is the most common complaint seen in children. So you have to give a removable appliance acting as a feeding plate so that the child can feed properly. In children, you have lot of tumors in the head and sometimes when the tumor is removed, there will be a big hole in the cleft area. So the obturator acts like a sealing place. So there are many uses of this obturator. First one, as I said earlier, for feeding purposes. Sometimes the child might be having a big wound or ulcer. So you want to place a plate to cover that wound to improve the speech in cleft palate patients. Sometimes in children with maxillary defects, you place a obturator like a barrier to close it to improve the mastication and deglutition, because when you place this obturator, the child is able to swallow properly, to eat properly, and chew properly. Sometimes it can be used as a stent to hold dressing. Sometimes a child would have undergone some palatal surgery. You want to place some medicine over the palate. So this obturator can act like a stent for holding the dressing over the wound area. So there are many uses for this obturator. So as you can see in this picture, the child is having a big hole in the palate. So this obturator is used for closing the defect. So it is used for correction of the defect. So there are many uses, there are many different types of removable appliances given in children. Thank you. Go through the slides. If you have any doubts, you can contact me anytime. Thank you.